Hi, I am Jason. I am 54 years old, and at 52, I was diagnosed with prostate cancer that had metastasized to my spine. And on this channel, we talk about it. Today, I've got a certified health physicist friend of mine, Jason Hout from Minnesota. We got a lot of good questions on radiation and safety and protocols, and so we're going to get right into it. Jason, welcome to the channel.
Hey, Jason, thanks for having me. It's really good to
Jason,
be here.
Jason, doctor.
Yep.
Yeah. Oh, man. So let's talk a little bit about what you do real quick. Can you give us well, your background, actually? I want to get into the background first because
Sure.
you and I knew each other at the Monticello nuclear power plant. What was your job there?
Yeah, we worked together there. I worked in radiation safety there for that boiling water reactor. Kind of got my start in the Navy, right? I think you were in a similar boat, right? So to
Yep,
speak.
so to speak.
I was an engineering laboratory technician on board the Carl Vinson for their refuel in the early aughts, let's say.
Yeah.
And then moved over to Monticello, worked there for about 13 years, ended up as a radiation protection supervisor, acting radiation protection manager, then moved over and did some manufacturing radiation safety for a large company in St. Paul.
Oh,
And
nice.
yeah, that was kind of interesting how they use sealed sources for measuring thicknesses of materials.
Oh, that's pretty
So,
cool.
so I helped them out with that, did a little bit of industrial x-ray safety as well. And then once the job came open at a large hospital system in the Midwest, I jumped on it because I've always wanted to use my skills to be able to help people. So
That's
that's kind
fantastic. And
yeah,
so then that's what you're doing now. You're helping people.
exactly. So, I help make sure that the uses of radiation that we use at these regional and community hospitals and smaller clinics are safe for not only the workers that work there, but also the patients.
Yeah. And when you're dealing with a lot of different types of radiation, a lot of different sources. So there's different types of radiation. There's gamma, there's beta, there's alpha.
Yep.
And the radioligand industry is taking advantage of the idea of attaching these different isotopes to a carrier of some type that targets PSMA
hmm
cells. And then that way it delivers radiation directly to those. So do you have any experience with any of these radioligand therapies?
I do a bit, yes. In particular, the lutetium-177 that's used for
Pluvicto.
prostate cancer, right?
Yeah.
That's one that I've got some decent experience with. Um, we've been expanding it out into the hospitals that I support, and so I've been involved in the licensing and basically developing the radiation safety program to implement there, and working with the nuclear medicine department to make sure that things are done safely, things are done effectively, and our patients are getting what they need. Before that, we'd have to basically shuttle our patients somewhere to get that treatment.
Oh, yeah. So when a patient is getting the Pluvicto, the radioligand therapy, what kind of protocols do they have to go through? Because that's a beta emitter, which you think that's not very penetrating.
hmm
I don't know what the half-life is off the top of my head, but
Yeah. So with that particular therapy, it's great because it can be done as an outpatient therapy. So I don't know all the qualifying specifics from the medical aspects of the patient, but I do know that once that patient's qualified to be able to receive the therapy, they basically come in for a short appointment and come in, they receive an IV, and we upload the lutetium 177 with that ligand into their bloodstream. It gets rapidly taken up by the prostate, and then we are able to release them into their home situation. And so part of the aspects of radiation safety is we have to make sure that the people that are receiving these therapies don't expose others to too much radiation. So we do calculations and analysis to look at that. One of the most interesting aspects about lutetium-177 is this treatment is rapidly excreted through the urine.
oh,
Um, And as you can imagine,
Huh.
patients receiving, this type of therapy for their prostate cancer may have, let's say, related problems with their bowels. So,
Yeah.
managing some things like, incontinence and stuff like that has been an interesting but enjoyable challenge.
Yeah. Oh, wow. So it's when we were working at the power plant and if we were ever in the plant, to exit the plant, we had to go through a portal monitor.
Hmm.
Do you have something like that before you release them? Do you
So
scan
what
them,
we
or is
do,
it all based on calculations?
there's a number of different ways we can do it. And the Nuclear Regulatory Commission actually gives out a regulatory guide, NRC Reg Guide 8.39, which discusses these methods, but it doesn't cover lutetium. So we had to
Huh.
kind of cover our own process there because it's a fairly recent therapy, right? You look at something like
Yeah.
iodine that's been out for thyroid carcinoma, that's been out for gosh darn decades. But lutetium was only, I think it hit the market in 2018 for
Oh,
prostate
yeah.
cancer. So it's relatively new, let's say. And so there really isn't anything in the reg guide about this, but they give the basic framework. So you can look at it from the total activity administered to the patient, and you basically assume that, basically the gammas that it's giving off. So it does give off a relatively low
Yeah.
energy gamma at a low yield. So
Okay.
specifically, it's 200 keV and it's about 11% yield. Um, Opposite of that, you look at, for comparison's sakes, cobalt 60, your yield with cobalt 60 at a power plant is going to be 100% of the decays, and you're going to get a 1117 keV and a 1332 keV gamma out of it. So cobalt 60 is much more energetic than something like
Yeah.
this. So,
Well,
but we look at that, right? And we look into you say, okay, well, what would be the exposure rate to somebody maybe sleeping next to that patient, or the exposure rate to a child sitting on their lap, or somebody sitting next to them on the plane? And so we have to go through all these calculations to make sure that we don't exceed the public exposure limit, for most people, as well as we get a little bit a higher limit for, let's say, the primary caretaker person's spouse usually,
yeah.
that's going to be there. We're allowed to go up to about 500 millirem for those type of people.
Oh, wow. That surprises me. Yeah. Okay. You touched on something that's actually a point of confusion when people are talking about when guys with prostate cancer are talking about different therapies and they're talking about Pluvicto. Some will say, I mentioned, hey, it's a beta emitter, and then some will correct me and say, well, no, actually, it's a gamma emitter. And that's a point of confusion with the Pluvicto. I think technically it is a beta emitter, but there are daughter decays that release the lower energy gamma as well. And the gamma,
Exactly right.
okay, and the gamma is more penetrating though, and that's what you have to be careful about. The beta is not a concern for other people. It's
Exactly right. The beta is not a concern unless you are going to physically expose yourself to the material itself,
right.
or ingest it or inhale it or something along those lines. The beta, we're not, it won't even make it outside the human body.
Yep.
But that's the nice thing about the gamma, is because it emits gamma, we can use it for uptake imaging, and we
Oh,
can make
yeah.
sure that the dose gets where it needs to go. So a lot of these patients come into the hospital, the next day after it's gone, because it goes in the blood first. It takes some time to build up into the prostate and get out of the blood. We bring them in like the next day to make sure that the treatment has gotten where it's supposed to go and is going to be effective for them.
And you can use that for the imaging. That's pretty cool. I didn't know that about that.
Yeah.
That's wild. Pluvicto, so that radioligand, lutetium-177, they attach it to a fairly small molecule,
Yep.
I think. And then there's a company called Telix that's got another version of lutetium-177 in trials right now. I think it's TLX-591, and they've attached it to a monoclonal antibody. So the carrier matters for what the carrier that they're attaching the radioactive isotope to matters because it does different things. And
Exactly.
I've heard I've heard it two different ways. I came back from the conference in August thinking that the monoclonal antibody was smaller when we bring the lutetium in to all the nooks and crannies and crevices. But then I read recently that actually the the Pluvicto is attached to a smaller molecule and it gets in all the nooks and crannies. And the benefit of the 591 is that it might have a little stay in the body a little longer. So is there any way you could shed some light on that for me?
So I know some very basics about that. That's not really
Okay.
my specialty per se, but
Yeah.
I do know that it's the chemistry. They bind it to a molecule, and the molecule is what determines where it goes in the human body. Um, eh,
Because
I
it
know
needs
for
something that binds with PSMA cells.
exactly, right? So they find something that chemically, let's say really likes to bond with those PSMA cells. And
Yeah.
for other cancers, it's the same type of deal. It's kind of an interesting technology, but yeah, it's so they find this basically they call it a carrier, right? They
Yeah.
attach it to this carrier, the carrier gets it there, and then of course most of these go through the bloodstream, so there will be a little bit of residual radioactivity left over in the bloodstream that has to get excreted. And then it really comes down to once the target organ takes up this molecule, the physical or the radiological half-life ends up being the predominant mode of decay. So
Oh,
what that
okay.
means is you're not sloughing off this material constantly through your body. There's
Oh,
going to be an initial release of it over maybe the first few days, but then it's going to really slow down because we want that material to stay where the cancer is and irradiate it over time. So
yeah.
that's kind of how that works.
And so the stickier the molecule, the carrier is, the better off it is.
Yep.
But so as a certified health physicist, there are some safety concerns with other exposures. Like the goal is to target those tumors, right?
Yep.
And like Pluvicto's really good at micromets, like it attaches to all that because it's really sticky with any PSMA cell. But that there are other cells in our body that it also sticks to, like salivary glands. The kidneys can uptake,
Hmm.
right?
Yep.
So what do we do to keep people safe from like kidney cancer? And I think one of the side effects I read about with Pluvicto was like dry eyes and tear duct issues.
Yep. Yep. It can certainly get in the lacrimal glands and whatnot. So all of that has to do with making sure that when the oncologist screens the patient for this, they're going to look at those type of aspects and make sure that the treatment's most appropriate for that patient. So that's really the decision from the doctor. My aspect doesn't really cover that portion of it. We have
Hmm.
we have a whole slew of teams at work. So so
A
I
lot
get
of
to handle more of the operational health physics side,
yeah.
and then we have other people called medical physicists who get to focus even more on patients and the effects of radiation on their body. If we get into talking about something like external beam treatments or something like that, the people who help review those treatment plans are usually medical physicists, and they're really smart. They have to
Hmm.
go through pretty much the same training that a medical doctor has to go through
Oh
in order
wow.
to practice. So and then you have the oncologists, you have the nuclear pharmacists, there's a whole team of people all focused on patient safety. And so my aspect of it is just one tiny fraction of it. But we do look at some of those things like you said, the dry eyes piece, right? So we've
Yeah.
had to evaluate, well, how much of it is really getting up in those lacrimal glands, and what are some of the potential side effects? I think I touched a little bit on incontinence. We've had to look at, okay, well, a lot of
Oh.
this is excreted through the urine. So if you have a patient wearing diapers or
Oh, and then
pads,
it absorbs and it's just collecting there and then they're
then
walking around. Oh
yep,
wow.
you got to evaluate for how often you're going to have those pads changed, because you don't want, that's where the betas will get outside the body, right, in that
Oh
urine,
yeah.
and then expose the skin. So you don't want the skin to be too far exposed, and avoid skin effects, which would be erythema, um, and reddening the skin. You don't want, especially in that area of the body, you don't want that type of issue going on as a side effect. So we've had to make some recommendations as far as radiation safety goes in those aspects.
Okay.
Um, you know, but generally we stay away from. That's usually the oncologist, the nuclear medicine pharmacist, and the medical physicist who will look at the other internal organs of the body. and make sure that they're not overexposed or having some harm caused to them.
It takes a village.
It sure does.
So, with things going on in the federal government, there's been a lot of cuts and a lot of cutbacks, but they're also with under the guise of trying to make things more efficient. And I know in the commercial nuclear industry, they're saying, "Hey, the NRC is overburdened. Overburdening. The NRC is this. And trying to cut back." What are you seeing with federal and state rules and how they impact hospital operation? Like, are we seeing benefits right now? Are we seeing um, any negative consequences?
Well, so the big thing about Alara when it comes to the medical setting and patient care is really there has to be a benefit to the patient by the procedure, right? And that
Hmm.
benefit has to outweigh any harms or risk. And so what we see generally is that regulatory bodies like the Nuclear Regulatory Commission, or really there's a lot of places that are regulated by agreement states, right? So you have the state that's made an agreement with the Nuclear Regulatory Commission, says I'm going to manage this myself. And so we work with our states. I still live in Minnesota, so I work Minnesota, Wisconsin, and we work with those regulators. And what we see is they're really supportive of making sure that we're doing things safely for the patient. But what we haven't seen is, you talk about some of the overbearing things, that or the perception that there was overbearing things that the NRC was doing in power plants. And I do know that they've backed off of that in recent years, because I actually
Yeah.
spoke with one of the commissioners. They came
Oh,
and
cool.
visited one of my facilities, and so I had they got rid of what they called the Alara inspection procedure a few years back, and so because
Nice.
yeah, I mean it used to be that working in RP at a boiling water reactor, we had 8 inspection procedures over a 2-year cycle, right?
It was
Um,
crazy.
so that level of engagement and involvement is a little bit less in the state. It's a little bit less periodicity, but I'm not seeing a whole lot of regulatory changes that are impacting us on a one way or the other. The
Okay.
limits are still the same right now for occupational workers as well as patients and their caregivers. And what I do see is a lot of support. So something new comes up, let's say, a new therapy or something like that. And so the
Yeah.
the regulatory bodies try to support that because they know it's going to benefit a lot of people.
So, are you familiar at all with any of the new treatments that they're working on? I know they're looking at alpha emitters.
Yeah, so there are some alpha emitters that are already out there, well established in the market. So like, I don't want to use a brand name necessarily, but radium 223 is a good isotope, good alpha emitter. I think that's used for bone cancers.
Oh,
Um,
I don't think I realized that was an alpha emitter. Oh, okay.
yeah, so there's a few along those lines that are already out there, but it's expanding. Um, because and I think where you're headed is maybe to actinium.
Yeah.
Um, but and I'm not too involved with that. Actually, some of my colleagues are involved in more of the safety aspects of that, because we at my employer, we do have a team of about 14 physicists to handle our entire healthcare system.
But I think my question really comes down to it's about the physics of the radiation and the differences between beta and gamma and alpha emitters,
Yeah.
because an alpha emitter is very penetrating. A beta emitter is very non-penetrating, like 1 or 2 millimeters max. A gamma is going to be extremely penetrating, or I guess an alpha is not as penetrating, but it's a lot more damaging. It carries a lot more energy. So when we're looking at what are we going to use and what are the effects and how does it impact those around the patient, I totally forgot what my question was. My question was,
Maybe a preference on which type of emission is
yeah,
better usually.
what are we how are we deciding which one to use?
Yeah, so there's a couple different things that play into this, right? And so we talked about the binding molecules earlier, where if we can obviously from a radiation physics perspective, if I can blast a tumor with alphas, that's going to hit a large helium atom
Yep.
essentially, right? So it bangs around like a pinball, so it loses a lot of energy in a short period of time and imparts a
All on
lot of
the
energy into
tumor.
those cells, right? And so it has a very high propensity for killing cells and won't damage the rest of the body unless it's right there and right connected to things. So you won't get any you don't have to worry about the organs really around it if you're ensuring that the molecules got good uptake into the target organ, which has the
Yeah.
cancer, right? So alpha's the best option you have if you can get it. The problem comes into, well, how can we get that into the organ? A lot of those alpha emitters, they'll tend to, they'll usually be some sort of positively charged ion. They or heavy ion or whatnot. They tend to be taken up into the bone,
Yeah,
right?
and that's
So
where I was headed. Is there's bone marrow issues? There's bone marrow concerns with some of these therapies.
Yep. Yep. So there's got to be some risk analysis there to make sure that, hey, we're using the right thing for the right person. Betas are a lot more prevalent when you look at the chart of the nuclides, right? Beta
Yeah,
emissions happen for the majority of radionuclides there are. And so and you make a great point with that, right? So, betas are less, they'll travel a little bit further before they expend all their energy, right? So then you got to start worrying about some of those surrounding organs wherever you're sending it to make sure that you're not going to overexpose it. And then, but that all boils down to, well, what's the fraction that's going to take up in the organ, how fast that's going to happen, and where else is it going to go in the body? And then that kind of boils down to, well, what's the right dose? What's the amount of activity that I need to give this person? And so when we talk about like lutetium PMSA treatment, that's a series of 6 treatments.
oh
Um,
yeah.
at and the number is going to be big here. It's going to sound big. 200 millicuries a treatment. So to give
Wow.
you
Okay.
to give you perspective, right? If any of your listeners are nuclear power
Nuclear.
related, right?
Yeah.
You'd have you'd talk in terms of DPM or CPM, counts per minute or decays per minute, right? And 1,000 decays per minute was something you considered contaminated. So you're looking at a microcurie is about 2 million DPM, and
Yeah.
here we're a thousand times that times 200. So
Oh
so
man.
the activities are large compared to what a normal person working with radioactive materials,
Used to.
outside of the medical industry would see.
Yeah. Holy
But
smokes.
you need something that big in order to kill the tumor,
Yeah.
right?
Fair enough.
But what they do is they space it out 6 treatments to help make sure that it's getting a constant flow of the right amount of activity into that tumor, and you're not affecting those other organs of the body as much.
That makes sense. Yeah.
So, like you said, the lacrimal glands, right? You can cause some serious damage to the eyes if you're gonna, you think, if you were to give them maybe all that treatment at one shot, you might be able to cause damage to the eyes that way, and that's something you want to avoid. So,
Yeah. Some of those can be scary. So, what is the thing you're most excited about in your industry right now?
so some of these new things, right? I'm always about helping, expand what's happening at the big research centers out into the smaller hospitals I support, right? Because you look at some of the locations I go to, it's rural Minnesota, rural Wisconsin,
Yeah.
right? And these are the hospitals that are, they've had iodine therapies for quite some time. Over the past year or year and a half, I've worked to get a couple of them lined up with Pluvicto in particular, so they could do that therapy and not have to transport patients back and forth. They're starting to get into some, away from therapy, but more towards diagnostic. They're starting to get into more PET or positron emission tomography imaging, which takes a really short half-life radioisotope, puts it into the body, they can scan it, and they walk out of the clinic and it's pretty much gone,
Yeah.
right?
When I got mine, they were using fluorine 18.
Yep. So that's what, 109-minute half-life. That's pretty,
Yeah.
couple hours, it's gone, right? And I know I've had friends and family be like, "Hey, I'm getting a PET scan. Do I need to worry about, having my kids around me or not?" And I'm like, "No, you're good to go, because it'll be out of your body by the time they get home from school." So, but there's ones that are even shorter now.
Oh,
We're
wow.
talking seconds, but they've had to develop technology because it's pretty much like they have to hook up a live feed, that's continuously pumping the radioisotope into you,
Yeah.
and then conduct the imaging. But pretty much once they take that away, you're looking within the next few minutes, you have no more radioactivity in your body
Well,
other
that
than what's
brings
naturally there.
and that true. And that brings up a question like where are they creating these isotopes? How are they transporting them? What goes into uh so fluorine 18, really short half life. I remember that they make it in I think a centrifuge
Hmm.
in Spokane, which is 3 hours away, and so they have to transport that amount of material 3 hours when it's got a 109-minute half life to
Yep.
get it in me to inject it. And then I have to wait 20 minutes or 40 minutes, however long it was, to let it circulate and then do the scan. So, like, there's a large amount of time there for a 109-minute half life isotope to be decaying. And when you talk about something that's in minutes or seconds, how are we creating, where are we creating them? How are we creating them? How are we getting them transported so that we can get it to the patient and still get the dose they need?
Yeah. So this is a great question. So, and it really emphasizes that the supply chain is supremely important,
Yeah.
to making sure that the patients get what they need, right? So just the physics of it, right? So this stuff's going to decay. So they have to make it larger and account for all that time,
A
right?
lot.
So a lot of times we work hand in hand with our supplier, and they'll know when we have a patient. So like
Hmm.
down to the time that patient is scheduled. So then they will deliver the dose in the morning before people get into work. And then once the nuclear medicine technologists show up to work, they've got the dose sitting there waiting for them to finish the receipt process and do the accountability to make sure they got the radioactive material that they got. They've got to measure it to make sure it's the right amount of dose that we're giving them. And then the patient comes in and it's a seamless transition.
Wow.
But it takes a lot of resources to get there, right? So I do have some colleagues that work for some of these companies. And I mean, we are talking Curies and Curies and Curies, and maybe, I mean, probably even larger than at the Curie level. I mean, you probably start getting to the gigacuries and teracuries or something like that. I mean, you start getting into very large amounts where you absolutely need hot cells, and the controls just get much more significant, for people working with this stuff. So, but yeah, that's what you need in order to get it there. From point of generation, you're talking, I mean, these isotopes that you've made a number of ways. A lot of them get made in research reactors or cyclotrons where they're bombarding a target with neutrons or some other type of heavier atomic.
Adam. Yeah.
Yeah, yeah, you know what I'm saying. So
Yep.
sometimes I lose words, but
We
but
we all do.
yep, yep. So, but then they've got it down to a science. They know exactly how much they need to expose the target for to get a certain amount of activity out of it, and they know that once they turn that beam off, it's going to start decaying right away. And then so it's all a timed evolution to get it there. They have to pretty much because working at a nuclear power plant, radioactive material shipping the waste out from a nuclear power plant, you had to go through steps, right? You had to,
Yep.
all right, so I'm going to fill the container, and then I got to measure what's in the container so I know what's in the container and know what controls I got to take and make sure the proper labels and all this other stuff. These guys have it down to such a science that they know the activity that's coming out. They know the radiation exposure that's being emitted from what's going in the package. So they know what the labels are going to be on the package. And so they just have to take some verification steps along the way,
Huh.
and then everything goes pretty smooth. Oh,
Well, that's freaking amazing, but it brings up a good point or a good question. Are people in even more rural areas that are away from some of these research reactors and away from these bigger hospitals, are they at more of a disadvantage of not having access to some of these more current treatments?
to a point, I think so. And this is my own opinion, just to be clear. Part of it is what I see is there's less avail. The radioactive materials license that I manage, you have
Yeah.
to spell out the therapies you're going to do at these smaller hospitals, whereas a large academic center or academic medical institution, they have their own internal process for approving new isotopes. So there's a whole rigmarole that you have to go through hand in hand with the state to make sure that they understand what you're doing and you get approved for it, then you can do it. I see a smaller scope at these smaller hospitals than I do at the larger center. However, I don't within that scope, the delivery and the supply chain pieces of it, I don't see a difference.
Oh,
So
okay. Well,
so
that's actually kind of good news.
yeah, so once these hospitals are approved for things like that, so if you go to one of the major suppliers of Pluvicto is Novartis, right? Pretty much the only one, but they've got a map where you can go and see where you can get Pluvicto treatment,
Oh,
you know,
I didn't know
and
that. All right.
they're in the middle of Minnesota and St. Cloud. There's a place in Maple Grove. There's a place. So it's there. It
Out here
just
we've
takes
got
yeah.
the Fred Hutchinson Cancer Center in
Hmm.
the Seattle, and it's I'm a patient advocate on a team. I was just on a call yesterday with Fred Hutch, and we have Spokane, we have the Tri Cities, we've got access to some of those here, and so it kind of puts the three spots, so the whole state's kind of covered. So
Yeah.
yeah,
And that's kind of how I see it too. I'm not too familiar with further west like the Dakotas or anything like that, but there's larger regional centers, and I know in the Twin Cities in Minnesota they've got University of Minnesota, they've got regions, they've got a couple different ones, right? And all these hospitals have teams of physicists and stuff like that to help this type of thing. So really it's I don't see it as a supply chain issue and getting there. In fact, I look at some of the Western Minnesota hospitals that I help, they get their shipments daily from the Twin Cities.
huh?
So they just got somebody that starts trucking, in the middle of the night or whatever, make sure they get there on time,
Wow,
does
that's
their
pretty wild.
deliveries and comes back, right? So I don't see delays on that end.
Yeah.
It is more about once we've done the research, gotten approval, how long is it going to take to filter that treatment through to these smaller areas? And there has to be a need for it too. I mean, you talk lutetium gets, for PMSA is going to have a lot more exposure because prostate cancer is the second leading cancer, right?
Yep.
They start getting into using lutetium for breast cancer now, right?
Oh,
Which has recently gotten some news.
oh, that's good.
And well, that's the leading cancer in the US. So that's going to start filtering now, right? So
Okay.
once they go through all their approval process that way. So that's really the holdup there is more about making sure that there's demand in these smaller areas and then getting the treatment to the patient where we can meet them.
That's awesome. I know that the Department of Transportation does have a lot of rules when transporting this stuff, so it can get a little burdensome. In
Yep.
fact, here's a fun little story. The Energy Northwest, the Columbia Generating Station, is out
Hmm.
on the Hanford Reservation. Hanford Reservation is all federal land, right? So the main road out there, the 11-mile road out there, is technically not public. It's a public road. People could just drive on it and go through it, but you're technically on Hanford land.
Okay.
So there's a weird rule out there when they're transporting radioactive material on that road on the Hanford Reservation is if the public has access to it, they have to do all these extra things. So what Hanford does is they just block the road when they're doing a material transport. They put the police down on the either end of the highway that the public normally has access to. Now they don't have access to it, and then they can bypass all those extra rules.
Yeah. Yeah.
Anyway.
So you're talking about, Department of Energy power plant shipments where there's usually high volume. The stuff is on
Oh,
a big
yeah.
flatbed
Oh,
trailer,
yeah.
right?
This wouldn't be high volume, huh?
No, it's not. I mean, you're talking a case that's maybe a small case, and you're talking these things are in syringes most of the time. So they've got a shielded container they're in. I mean, literally the vehicle might be a minivan that they're shipping them in,
What?
where
Oh, wow.
somebody's trained, but the dose rates outside the container are not significantly high where the driver's going to get a lot of dose,
Right.
you
Because
know?
the shielding is really,
Yep.
really good.
Yep, you've got shielding in the container, shielding in the syringe holder, and then these containers are all tested to make sure that hey, if the car gets into an accident or something like that, they're not going to leak all over the place, you
That's
know.
good.
So they have for those type of shipments, the DOT specifies certain tests and certifications that whoever's responsible for shipping the material has to ensure. So these companies have to do that. We usually ask them because we sometimes ship things back for their certification. So that way, when we make those shipments back, we can have that available because that's required in the paper trail. And then, yeah, all the different signage, and you've got different dose rate limits for different classifications of shipments and all that stuff. It's quite complicated.
Yeah.
Because
Holy smokes.
I know when I first got trained to do shipping, it was about a week long course that I first took it. We generally, I mean, we have nuclear medicine technologists and sometimes research folks and stuff like that in our hospital system conducting these shipments. We try to boil it down as much as we possibly can, so that way it's this type of shipment, put this sign in it, and really get people down to using checklists and stuff like that. So it's
Yeah. All
it's
the human
safe, and
factoring.
we mitigate all the human factors out of it. So that way it's, and if we do fail, we fail conservatively.
That's
So that
awesome.
way, yeah.
So where do you see the future of radiation safety headed with the rise of some of these new radioligand and like the alpha emitters? This is a developing thing with the success of Pluvicto. There's more coming out. There's another lutetium-177 that's in phase 2 trials. Where is the future of radiation safety headed with all of this?
Yeah, I think that's a great question, and I don't think there's not anything like on the horizon that says here's where we're headed right now. It's more that the radiation safety industry is responding to what's happening, right? As it
Oh,
comes up.
that makes sense. Yeah.
And so what I see is that we're getting more exotic in the things we do. It's not just iodine 131 anymore, where it's a beta emitter, where it's going to go, what it's going to do. And some of these treatments are on the market before we have a full understanding of how they're excreted from the body, and all these other things. I mean, we study these things a little bit, but they're each patient is different.
Oh,
and
yeah.
and so it's not just a reference man that you can say, well, it's going to be excreted this fast from the body. You have to kind of figure out what's the best deal there, especially when you get into complications like renal complications for a Pluvicto patient, where you may end up with, maybe it comes out faster, maybe it comes out slower, and then you've got to manage it. What we're seeing now with that patient population shift is patients are coming back to the hospital more often. And so we have to help make sure that material that's coming out of their body is well managed in the first few days. So we're looking at things like broadening our scope to, all right, well, we put in a system at my employer where I see it if a patient has an appointment in one of my facilities, or comes back through the emergency room, because that's happened before too.
Oh, yikes.
So there's like a right sizing there that has to happen to make sure that, because you want the staff that's taking care of that patient to know and feel comfortable with what they're doing, right?
Yeah,
We've
that makes
already done the
sense.
calculations in the background, but somebody at a facility that doesn't deal with radioactive material may not have the training. So we have to have
Yeah.
deployable, on the spot training, stuff like that. And
Oh,
that
wow. I never even thought
reminds me
about
of,
that.
I dealt with that situation. What was it, last year? Or yeah, I think it was last year, last fall or so. I had a patient come through the emergency room, and ended up having a 5-day stay after they had Pluvicto treatment. So
Oh, wow.
part of that was, okay, well, I'm running out there. I keep
Yeah.
a Geiger meter in my truck so I can do this, right? So like, and we joke that we're gonna start. Yeah, we're going to start giving me a sample counter at home here to sit in my office and whatnot. But yeah, so I will deploy rapidly to the site if they don't have the capability to handle it by themselves.
Yeah, because they don't
Um,
know. They don't know what to
exactly.
expect, and
And
it could be scary to them if that not knowing could be scary.
oh yeah, for sure. You think about, there's a lot of young people that work in healthcare, and there's a lot of women that are starting their family. So there's a
Yep.
lot of pregnancies, and a pregnant
Oh,
mother
yeah.
is going to be very concerned for their unborn children, right? So getting out there and making sure that, one, we aren't spreading material all over the place. The material is not much of a safety concern. It's more of a, we want to keep it up because we don't want, let's say somebody's crawling around the halls. I mean, the public's here. So we just want to make sure that we control it well, right? So, get on site, do some of that, and then I'm training the staff,
Oh, that's awesome.
you know, and saying, well, here's really the risk. especially healthcare, right? So they know that x-rays exist. They know that people working with x-rays sometimes wear lead aprons. So they're thinking, well, gosh, I should have a lead apron. Well, not
Mm.
really, because like we said, the primary thing here is this is a beta emitter. So it's unless you ingest or have it on your skin, you're not going to have a health risk to your unborn child. So, we just need to monitor for the material, decontaminate if we find it, and then move on with our lives. But yeah,
That,
yeah, it's been some interesting stuff. I am kind of excited to see. There's been a lot of talk about AI though, and
yeah,
and I
how is
don't
that
have much.
rolling in?
I don't have a lot of specifics on that. I think when you're talking radiation safety, they're still finding a niche, let's say, or finding the right fit.
Yeah.
But I know in radiology and stuff like that, AI is starting to be used heavily to interpret images.
Yeah, that
So
was something that came up at my August the Zero Cancer conference. Is they said, "Hey, what we did is we took a huge sample of images that had already been read, and we sent them through AI, and AI was finding incidental things that were not related to the primary thing that the doctor was zeroed in on, the reader was zeroed in on." And so it was, oh, by the way, they've also got these kidney stones. And although, by the way, they've also got this. And what about this spot in the brain? They may that might be a brain tumor. And
mhm.
so the AI is really good at interpreting those things from the scans. And I wonder if someday in the future we might be seeing AI used to help map out. We've got this patient coming in. They're coming in for some new future treatment, and it's this type of emitter, and here's the patient history. They might have kidney disease, they might have some heart disease, they might have some cardiovascular issues. The AI maps out, this is the expected exposure, this is the expected uptake locations, this is the expected risks, and actually analyzes all that risk and can tell us, hey, this is the right treatment, this is the wrong treatment, this is the right dose, this is the wrong dose.
Yeah, it'd be nice if we could get to that point for some of the things that I'm doing too, like occupational safety,
Yeah.
and maybe we get away from using passive dosimetry to monitor exposure, and we do
Ooh.
it based on what the machine output characteristics are, and whatnot, because that's a huge burden on the healthcare system, the individuals, as well as radiation safety. There's a little bit of budgetary influence there too. I mean, we have about 5,000, a little over 5,000 people that we monitor for their radiation exposure, um,
Wow.
using TLDs, for passive dosimetry. And so each one of those has a cost associated with it, and they have to exchange them at either a quarterly or a monthly frequency. But we can predict what the patient exposure is when you're using something like fluoroscopy, right? We know what the patient is getting for dose, and what the worker gets is just a fraction based on the radiation that's scattering off the patient.
Yeah.
Why couldn't we calculate that out? I know there's
Oh,
part of it is there's differences in how you angle the C-arm creates differences in the radiation field for the worker, right? Because it's not a homogeneous radiation field that's gradient, right? Usually
yep,
the stomach and the waist get a higher exposure level because you're closer to the patient at that area than
yep.
your head, right? But if we
But
could figure out a way to do that with AI and do those complicated
that mapping,
calculations, yeah,
yeah.
that'd be a way to look at it for the future.
Oh, that's pretty cool. Well, we've talked several times now about this, not the patient themselves, but their loved ones or whoever's with them. What would you tell patients or families who worry about the radiation in hospitals?
Yeah, so that is a good one. So you have to talk about it from a couple different aspects, right? Because there's a diagnostic imaging component. There's X-rays, CT, all that stuff. All that stuff uses radiation,
Yep.
and so what we do is we evaluate for those uses. We kind of look at, well, how often are we using the machine, stuff like that. We actually put lead shielding in the walls to
Oh,
ensure that the public is not exposed too much. So
I never thought
so
about that, but that makes sense.
yeah, yeah, those are some of the calculations I do, right?
Huh.
So I help with that aspect, and we'll walk down new construction when we're putting this stuff up to make sure there's the right amount of lead is in the walls as we want, and whatnot. So that's an aspect of it that one aspect of it, right? So you might have a patient waiting room that has chairs right next to your x-ray room. That person could be sitting in that chair, and they won't get exposed because we've got lead in the walls. So it's gonna shield that. On the nuclear medicine side, on the really, it comes down to people are gonna be worried more about their, the people at home. They're
Yeah.
not. I haven't seen many people worried about, am I getting dose from another nuclear medicine patient in the hospital? So they're worried more about, well, am I
Huh.
bringing this home to my family? And so we do calculations to make sure that person and their family members are not going to be exposed more than they should be, and the risk is really small. um, I forget if we mentioned it during the recording or not, but here, so the limit is 500 millirem, right?
Yep.
And so 500 in context there, I mean, you are looking at a fraction of a percent potentially increase in cancer risk compared to a baseline of about 40% incidence naturally, right?
Yep.
So the risk is
Yeah.
very, very small. And if we get somebody that is, you know, let's say they sleep with their child, okay, we'll give the
Hmm.
patient instructions and make sure that the patient can follow those instructions to make sure that we minimize that exposure to other people.
Okay.
So yeah, while the especially while the material is coming out of their body, we do things like asking male patients to sit when they urinate and flush the toilet twice to make sure that,
Oh.
you know, eh, take their toothbrushes out of the bathroom, put it somewhere else, things like
Oh,
that to help minimize things, right?
I don't think I
Um,
heard either of those when I got my scans.
Well, because your PET scans,
Because
that's going to
the
be out
PET
of your
scans
body
is going to
so
be
fast,
different.
right? This is
Yeah.
something that we do for radiopharmaceutical therapy for cancer treatment,
Yeah.
where we
Yeah.
know the material is going to be in the body for a significant amount of time. Um,
That's
so like,
pretty in depth. Thinking that's a lot of thinking ahead. Like, what about this? What
yeah,
about this? That's really cool.
we,
That's awesome that you're getting that involved
we,
in.
yeah, we look at all kinds of things. We look at, well, how did the patient get here? How are they getting home? How are they traveling within the next week or so? Things like that. And so we'll give them instructions for, hey, if you've got a cross country flight, you should probably delay that by a day just to make sure that the other people on the plane aren't getting exposed.
Wow,
And so, yeah,
that's
yeah.
pretty cool. So you've answered a lot of my questions, and before we wrap this up, I want to give you an opportunity. Like, just the floor is yours. What is it that you want to share with our viewers, if anybody stuck around this long, to know about what you do, about the industry? Um, what do you want to tell them?
Well, gosh, there's probably a couple points. The first point is anything that we do, the medical community that uses ionizing radiation, it's for the benefit of the patient. We make it as safe as possible for everybody, but there's a tremendous upside to using this radiation for the person that we're using it for. And so that balance of harms is definitely considered, and it's a positive effect. Okay. So on the other side of it, the risk of any consequences to anybody, being around a nuclear medicine patient or X-rays or anything like that is super low. It's usually not even measurable. So the point is it's very safe. Okay. And so I wanted to key on that first to make sure that everybody knows, hey, this is cool. There's a potential here for there to be some issues, but we
Yep,
manage it so it's very safe.
it's awesome.
The other piece, so it's really an exciting industry. You hear about all these things happening that can help
Yeah.
people out, right? So to get into a line of work supporting this, so I'm sure you probably have previous coworkers and colleagues looking at this stuff too. So if they ever want to make a jump out of nuke power, let me know. I'll let you know when we have a job posted. But
That's
I mean,
awesome.
that's so like we and that's one thing we do too is, we will hire folks with a background to make sure, because it's well adaptable to something like this,
Yeah.
and it's great to have different experiences and viewpoints brought in to make sure that we're getting a well-rounded view of safety when we're looking at things. So yeah, I mean, we're growing. We're a growing industry. One of the rare times in my career that I've been part of a growing industry. It's nice
True.
nice to be a part of that.
Oh, very cool. Very cool. I've sure enjoyed having you on the show today.
Yeah,
This
I
has been
appreciate it. Thank you.
so much information. It's almost an overwhelming amount of information, but it's fantastic. There's so many things. Yeah. I think I'm going to be thinking about this as I'm editing this video and like, oh, I should ask this and I should ask this. We might
Well,
have to have you back on in the
it
future.
might have to do that. Yeah, that's fine. I'm open for that. So yeah.
All right. Well, thank you very much.
Yeah, thank you.
It's been fantastic, and for all the viewers, they've stuck around this long. Awesome. Love you all.